David Johnson, Professor of Medicine and Chief of Gastroenterology at Eastern Virginia Medical School in Norfolk, Virginia, and welcome back to another GI Common Concerns. Today I wanted to highlight some new information as it relates to menopause. Certainly it's a very common condition in women in the U.S., approximately 1.5 million per year enter into menopause, and hysterectomy is one of the most common surgical procedures for women worldwide, and it's estimated that 20 to 40% of women will have a hysterectomy by the age of 60. So it may be biologic with age, or it may be surgical by induction and oophorectomy. So let's talk about some symptoms and really what's new on the information as it relates to menopause. First is there are functional things that change as it relates to the hormonal and changes in hormonal balance, and certainly it affects GI motility, increasing abdominal muscle stimulation as it relates to different patterns of secretion. But there are a number of things that change, and food intolerance is one of these. Particularly, we think is related to multiple things, maybe related more to biomic changes, but diet and certainly activity, sleep cycle, all these things play into microbial changes. But there may be food intolerances which are triggered in the menopausal patient or the perimenopausal patient, which you may need to go back and start to ask the questions. What is it? Certainly FODMAP diet that we all know about as a fermentable oligodia or monosaccharide and polyols, or FODMAP diet, is known to reduce symptoms, but this is not the end all for every patient just to give them a diet and say you have irritable bowel. Certainly there are other things that can be done with this, and the data is very strong that adjunctive use of a dietitian is very much helpful in this particular population. If we talk about the menopausal patients, though, then we're talking about changes in activity, maybe other stresses or their mental conditions that relate to stress or anxiety. There may be a sleep intolerance, which we'll talk about in a second. But these things all play into more a multifactorial composite, which irritable bowel is a great example here in the menopausal population. But it may be that we need to expand our horizons rather than to focus this just as an antispasmodic or a diet-related intervention. But we start to look at more of a combination, a multifactorial or a multidimensional treatment approach, consisting of things like education, relaxation, and cognitive behavioral therapy, physical activity, and certainly there are behavioral interventions now using internet-based digital formats to increase the acceptability and sustainability. So again, a multidisciplinary approach to these patients may be quite helpful. Let's talk about what also happens when you change hormonal balance, in particular as it relates to other metabolic health. Using a rat model, a recent study looked at this, and they looked at oophorectomized rats, and they found that there was a biologic change in diversity in the general GI biome, but there were concordant relations as it relates to the cognition and the BMI, so the weight-related changes, and that there were changes that were dramatically also related to the spatial memory and cognitive performance characteristics of these rats, which was improved then by supplemental estrogen. So again, these are things that may be remedial to supplemental hormonal replacement treatments. In that same light, there is another recent study that looked at NAFLD, non-alcoholic fatty liver disease, which is very common in general population, but in the prevalence in postmenopausal women is greater than 20% worldwide. And a very interesting study, albeit somewhat small in the numbers, looked at the method of how the hormonal therapy is delivered, be it transdermal or by oral. Recognized still they're relatively small study. There were 75 patients in the transdermal and 293 in the oral. And then they looked at ultrasound definition of non-alcoholic fatty liver disease, and the endpoint after a year, there was a 7% reduction in NAFLD in the patients that received the transdermal, again, small number, but there was a 4% increase in the patients that received it orally. So there may be some route that makes a distribution change as it relates to non-alcoholic fatty liver disease. I mentioned sleep, and this is something that's near and dear to my heart, and a lot of our research is focused on this, but sleep disturbances are really part and parcel, some of the core principles of menopause, and we see this as it relates to hormonal imbalances, temperature intolerances, but sleep fragmentation, shorter reported duration, poor sleep quality. But what this does has a dramatic effect not only on biome, but it also has effect on sensory threshold. So as we start to look at mitigating strategies here, we need to focus on sleep and start to ask the question. My own favorite question is to not just ask, how did you sleep last night, because sleep can be somewhat amnestic, so you may have a cognitive awakening or a non-cognitive awakening, but still fragmentation. So my focus is really on next day function. When you get up in the morning, are you refreshed? Do you have daytime activity? Early fatigability, cognitive changes that occur. These are things that are a good look back at the night performance as it relates to the sleep efficiency. One final area that I thought was really very interesting too is looking at the effects of menopause on osteoporosis. We certainly know that postmenopausal women have very high prevalence of postmenopausal osteopenia, and certainly osteoporosis is a progression of that, and increased bone-related disease effects, fractures, and related morbidity and mortality. But there's growing evidence on biomic changes in menopause as it relates to these osteoporotic effects, and there's accumulating evidence that show that the biome regulates the pathophysiologic process of at least a large degree of osteoporosis. Why is that? Well, it starts to make sense when you look at the pro-inflammatory factors that go up with biomic changes in diversity, in particular as it relates to TNF-alpha. That's an inflammatory bowel disease for sure, but things like interleukin-1, and in particular as it relates to osteoporosis, is increased activated osteoclasts. So again, when we start to look at our perimenopausal or postmenopausal women and start to look at what do we do to decrease their bone risk, the answer is really not in yet. Hormonal therapy, maybe, diet, activity, all those things that change biome and activity-related changes, vitamin D supplements, these are things to talk to their OBGYN doc or their primary doc, a little bit of, I'd say, the pay grade of the gastroenterologist, but certainly to have them ask the right question. So in my perspective as a gastroenterologist, there are a number of things that are new as it relates to menopause, and we need to be more proactive, ask the right questions when these people come into you, irrespective of why they're there. Maybe start to ask about how their sleep is, what are their functional symptoms, what are their other potentials as it relates to osteoporosis related risks, and do a better job as we start to individualize care. Rather than treat patients as disease states, we start to do specific patient-related focus care. Dr. David Johnson, hope this gives you some provocative thoughts when you have your next session, when you see your next patient in the perimenopausal or menopausal state. Again, lots of things that we continue to learn. Thanks for listening.